Hello and welcome everyone. Um, the music always makes me chuckle because it shows you the quality of my bandwidth or Helen's, but I'm sure that's not quite how the composer had intended me to listen to it. But hopefully it did its job and it settled you and relaxed you into our session this afternoon. We've been very privileged to hear some excellent presentations this afternoon, and really looking forward to the session with Ipsos and NHS England, I guess in many ways bringing it together as we hear about patient experience research and some of the things that the team have been hearing. So my name is Ruth Evans. I'm one of the founding directors of the Patient Experience Network. And for those of you who've not heard about us, which may be many, we are, I guess, we were set up to really put the spotlight on good practice and give people a vehicle to be able to celebrate what is working well. And so it's a real privilege and honour to be alongside the NHS England team and the presenters today to share some of the things that are working, but also to understand where else we need to be focusing. I'm joined by some of the team from Penn today, so you will be seeing or hearing from Louise, particularly in chat, as she'll be making sure that we've got all of the tools at our fingertips in the chat, but you may well meet her in one of the breakout rooms. Louise is the head of operations, and many of you will have probably met virtually Helen because she's been looking after the logistics and the administration. We were very lucky to be invited to support this project or this set of sessions. And so our role today is very much managing and coordinating the back office organisation of this. So if you've got any questions about the logistics or you've got technical issues, please drop us a note, probably in chat, or just let us know and we'll see if we can fix that. But the sessions are very much owned by each of the speakers. And so we've had a series of different groups through the day, and it's very much their session. So if you've got questions around the content in particular, then it's probably best to ask questions of the speakers. And the best way to do that, for those of you who are perhaps not so familiar with Teams, because we don't all live in a Teams world, is across the top or somewhere on your page, you'll have a ribbon of icons. And the best way, I think, to get hold of people right now is by clicking on the speech bubble that says chat. And if you do have that bubble, then you'll be able to pop in a question or some information that you want to find out about. If you don't have that bubble, you may have a raise your hand, and the raise your hand is where you can literally put your hand up and we'll stop and invite you to speak. We will be breaking out, but we'll explain how we break out later on. And don't worry, there's nothing you can do wrong, because the worst thing you can do is drop out of the meeting and we'll find a way to get you back. So as I said, Penn is a not-for-profit and we're here to celebrate or put the spotlight on what's working well. We're very much looking forward to looking to the session this afternoon. We've had some really, really invaluable insights, and I'm sure that conversation will continue. In a moment, I will hand over to the team who will be looking after the session, which is Kate, Michelle and Laura. But first, I'd like to pass you to Neil Churchill, who is one of the directors at NHS England with a responsibility for experience, participation and equalities. So who could be better placed to talk about some of his thoughts for this session today. So Neil, over to you.
Hey, thank you very much, Ruth, and thank you everybody for coming. I'm not going to say much from my experience because I'm just learning a lot from being here. It's interesting that as I've listened to the sessions throughout the day, there's been some things that are familiar to me and a lot that's been new, and it's been invaluable really to listen to people who've had experiences of long COVID, family members, people working with patients with long COVID, just about what we're learning, and really valuable, I think, to have a day like today so that people who are not necessarily working in the field, as well as others who are, can share some of those insights. So Ruth, I want to say a big thank you to you and to the Patient Experience Network and your colleagues and all of our presenters today for giving your time, as well as all of you for coming and joining in. I think it's been a real classic case of why it's so important to start with people's experiences when we're trying to understand what people need, and the quality of care that we need to design. And it's always important, but I think it's particularly vital when we're dealing with something new and as badly understood by many as long COVID. I think we've heard a lot really about how people's experiences are affecting their wider outcomes, how they're experiencing their quality of life. And we had that, Ruth, you drew attention to it earlier about a young person saying it felt like the colour had drained from their life. I think that's a memorable image, isn't it, from today, about what this condition can do. So I think looking forward to learning some more. I think one of the things I do want to do is just to remind us all that a lot of what we're hearing is transferable learning, and there is other learning that's relevant to us, particularly I think when we're talking about what some of the barriers and enablers are to accessing care. We know a lot about this. There is a lot that we know, both in terms of particular conditions which might be relevant, but also for particular groups of people. And I think that's one of the things that really COVID reinforced was the need to think about groups of people who do find particular barriers in accessing services, and also some of the things that really work in overcoming that. And in that, I want to pay tribute to the work of the Health Wellbeing Alliance and a number of voluntary organisations who've recognised some of the commonality between different groups of people who have had some of those difficulties in accessing care, and thinking about how we need to work differently to just encourage us all who are involved in commissioning and providing services to start with people, and understand the differences in people, understand what people bring, and to look beyond individual conditions. And nowhere really, I suspect, is that more important than in long COVID. So there is transferable learning. I think one of the things we're keen to do is to make sure that as we all invest in understanding this better, that we share what we're doing, we support each other in understanding that insight, and that we are better able to focus on some of the gaps, and clearly there are gaps in our knowledge, and we do need to think about how we approach them. And one of the things that's crucial to that is the value of people with lived experience, and it's been great today that it's had such a strong flavour of people's lived experience, and really bringing alive what it's like to live with this condition, to try and access services, and what it feels like when those services don't quite give you what you need. So I think looking forward to what more I have to learn from today. It's been fantastic so far. Thank you very much for coming. Ruth, I'll hand back to you.
Thank you, Neil. We've thanked the speakers, and we've been reflecting on some of the people who've been able to make this so, but we should also just mention Nina and Joe, who have coordinated all of the speakers today and brought 3 fantastic sessions to bear. So Nina is online with us, so if you have questions for Nina, she's with us, but I just wanted to reflect on Nina and Joe's spectacular work as well. We've been asked several times about the resources, and the resources will be available on our website. So for those of you who've not been to our website, it's very easy. It does what it says on the tin. It's www.patientexperiencenetwork.org. But don't worry, we'll send all of that information out to you. And on our website, we do have case studies, and there's a couple of case studies that, as you're thinking about how you might change your best practice or you adapt to reflect on what you've been hearing, there are there's a couple, but there's one that jumps to mind that was one of the shortlisted organisations. In fact, I think they were a category winner last year, which was all around supporting patients with long COVID. So as you go onto our website, you might find it's worth mooching. I am conscious, though, that you're here to hear our speakers, so I would like to hand over to the team who are looking after us for the next nearly 90 minutes, Kate, Michelle and Laura. Kate, I think it might be you I'm handing over to, but let me know if I've got that wrong. I will go quiet and hand over to the team from Ipsos.
Thank you very much. Much appreciated. Thank you. Afternoon, everybody. Thank you very much for joining this session. We're really pleased to be here to be able to present our research to you that was commissioned by NHS England and which we've conducted together as a team. Laura's going to start off for us just by telling you a little bit about what we've been doing and what we were aiming to achieve from that.
Hi everyone, hopefully everybody can hear me. Looks like that's a nod. Okay, great. So hi everyone, my name's Laura. I'm part of the research team at Ipsos that worked on this project with NHS England. So as Kate said, I'm just going to introduce our research and talk through the first section of our presentation, and then I'll hand over to Michelle and Kate, who will take you through the rest of our slides, and then lead us through some breakout sessions to talk through your thoughts on what we've heard. So the slide that you can see at the moment is an overview of our research program. As you can see on the slide, the project was divided into 4 different strands. The first 2, strands 1 and 2, were designed to provide an in-depth understanding of the barriers and enablers to accessing long COVID care. So they had a focus on 3 lesser served patient groups, which were children and young people, people with long-term health conditions, and people living in deprived areas. Strand 1 involved depth interviews with people who self-identified as having long COVID, but hadn't accessed long COVID services. And Strand 2 interviews were with advocacy organisations working with those underserved groups. The third strand, so that's in the dark blue box, was a nationally representative public survey, which we conducted in April last year, so 2022, using Ipsos Knowledge Panel, which is a random probability online panel. And that strand gave us an up-to-date, at that time, understanding of public knowledge about long COVID, as well as an understanding of public attitudes towards long COVID as well. And then strand 4, the final strand, was another set of depth interviews, this time with adult patients who were using post-COVID services in England. The strand was aimed at looking at understanding patients' experiences of post-COVID services, trying to identify where services were working well and how they could be improved. So our presentation today is going to look at findings about barriers and enablers to accessing long COVID care across all 4 strands of their research, with a particular emphasis on communications about long COVID. I should also point out here that because each of the strands focused on different specific groups, we can't compare findings across the different strands, but we do triangulate the findings across the research. So if we move on to the next slide. So throughout this presentation, we're going to highlight points along the long COVID pathway where information and communications are particularly important and where they could be improved. So we're going to do that by looking at findings on the topics that are shown on this slide. So things like increasing awareness of and knowledge about long COVID, providing advice through NHS channels and helping people to self-manage their symptoms, providing more information while patients are waiting for their first appointment with a long COVID service, embedding best practice based on patient experience and feedback, and making NHS information easily accessible in a variety of different formats. And the next slide just takes us through to look at the long COVID pathway that is in place at the moment. So if we skip again to the next slide, we've got a chart that breaks down some of the key points, thank you, along the pathway, going from awareness of long COVID through to initial contact with services, through to actually getting care from long COVID services. The purple arrow shows the direction of travel, and the green boxes show those key points along the pathway. So things like the point at which an acute COVID-19 infection, and then when they've sought information about long COVID and then accessed a long COVID clinic towards the end. The blue boxes on this chart are a range of enablers that we've identified through the research program. So in our presentation today, we're going to talk through the enablers that are outlined in red, which are the ones that I identified in the previous slide. On the next slide, we've got a video from Vicky, who is one of the lived experience partners who helped us to design this research program. Vicky has recorded some video clips to tell us about her experience and that of her daughter, Hannah. So this is the first of 4 videos we'll share in this presentation, where Vicky introduces herself. So if we could just play that video.
So I'm Vicky Collins, and I've also got a daughter, Hannah Collins, who was 13 when she first became ill, but she's 15 now. And both of us unfortunately had long COVID. We both caught COVID in March 20 initially, and my daughter recovered then, but I sadly went on and carried on feeling really poorly, and yeah, that continued for about 2 years until I got some help. And my daughter caught COVID a second time, July 21. That was when she got long COVID. And has been really, really poorly. And she was hospitalised in October 21 because she was paralysed from the waist down, and she'd been also really, really poorly several weeks after having COVID. And she's recovering now, and yeah, she's hopefully on her way to being better.
Oh, thank you. If we just move on to the next slide. So I'll start by going through this first area of the pathway that we talked about before. So areas where the research demonstrates that information and communications are really important. So we'll just talk through what that means for services. The first topic is about increasing awareness and knowledge of long COVID as a condition. So the chart on this slide shows us the results of our survey question, which was about how much, if anything, would you say you know about long COVID? So essentially, awareness of long COVID as a condition was quite high, with 91% of the public claiming to have some knowledge about long COVID. But the top level awareness of long COVID doesn't tell the whole story, because that 91% included half, or 50%, who said that they knew just a little about long COVID, which indicated that there was a self-perceived gap in more detailed knowledge. And then a further 9% said that they had no knowledge of long COVID at all, or that they'd never heard of it. And there were some groups in particular who were less likely to know about long COVID, for example, people from ethnic minority backgrounds and people who are living in the most deprived areas of the country. And on the next slide, we've got a chart about symptoms of long COVID and how people feel about those. So there is an overall belief among the public that long COVID is a real condition. There's also widespread agreement that long COVID symptoms can affect people's daily lives. So as you can see on this chart, 9 in 10, or 91% of those who say that they know at least a little about long COVID agree that long COVID symptoms can affect people's daily lives, and 85% believe that long COVID is a real thing. But there's less of a consensus about other aspects of long COVID, so things like whether long COVID symptoms can change over time and whether long COVID can be treated. And a significant proportion of the public neither agree nor disagree, or don't know about these more detailed aspects of long COVID. Some of the knowledge about long COVID was also quite surface level. For example, 34% thought that it could only be diagnosed if there'd been a positive COVID-19 test, which might deter some people from presenting with symptoms because they don't realise that long COVID is a possible explanation of what they're experiencing. And then the implication of that is that people might not be confident about recognising they have long COVID. And on the next slide, we're looking at where these perceptions and misperceptions might be coming from. So you can see on this chart that the public is largely getting information about long COVID from non-NHS sources. More than half the public, or 55%, said that they'd heard or seen information about long COVID from TV news or programs, and around a third of the public said that they'd heard about long COVID on radio news or in newspapers, which were both around 32%. And then another third, or 34%, said that they'd heard about long COVID from friends and family. And on the next slide, just showing that the public has low awareness about long COVID generally. So there's a specific lack of awareness or misunderstanding about how long COVID symptoms progress or evolve, how long COVID's diagnosed, whether the severity of the acute COVID-19 infection is linked to the severity of long COVID, and also whether or not long COVID can be treated or cured. And this lack of knowledge is a significant barrier to accessing care, which could be addressed by improving visibility of and access to reliable NHS information and guidance. And then on what I think is my last slide, there's one factor about long COVID is that it can be difficult to recognise. And people aren't necessarily aware of the breadth of symptoms that it can cause. So on this slide, we're showing that around 7 in 10 of those who knew at least a little bit about long COVID, or 69%, were able to identify fatigue as a symptom of long COVID without being prompted. People were also able to recognise breathing problems, including breathlessness. So about 38% of the public recognised that unprompted. but 16% of the public weren't able to identify any symptoms of long COVID without being prompted. So in addition to that, across our interviews with people experiencing long COVID, those who had acute COVID-19 early in the pandemic reported not realizing that their ongoing symptoms were indicative of long COVID because there was low awareness across the population and healthcare profession that such a condition existed. And some other health conditions also have symptoms that are similar to those of long COVID, which can make it really difficult to identify long COVID as a separate condition, especially among people with other pre-existing conditions. So it's really important for the NHS to improve public awareness of the various symptoms of long COVID so that people can recognise when they're experiencing it and seeking help. And I think at this point that I'm handing over to Michelle, who is in the room with me. Is that right? One more. One more? Oh, one more for one more. Yeah, so it's really important to, last point is to increase public awareness about long COVID in children and young people. So people perceived that messaging from public health and the government in earlier stages of the pandemic had minimised the risk to children, and they felt that there was a perception that only adults could develop long COVID, which isn't correct. And there are some quotes here at the bottom to give some indication of what parents were saying. So the quote on the top left there was from a parent of a young person aged 17 who said, I remember at the time seeing Dr. Jenny Harris on the TV saying kids don't get COVID, they're more likely to get hit by a bus. So it just sort of gives you an impression of the strength of feeling that's coming through in those interviews. And on the next slide, this is my last slide. So the importance here is about increasing healthcare professionals' knowledge and awareness of long COVID symptoms. So if healthcare professionals' knowledge is increased, this will improve public confidence in healthcare professionals and their ability to treat long COVID. So it will give people more confidence to approach their healthcare professional and confidence that they'll be able to identify long COVID and recommend a suitable course of treatment. In particular, there was a recommendation from lots of participants that it be advertised that it's not necessary to wait until the 12-week point post-infection to seek care. So I think that this is the actual point where I hand over to Michelle. Thanks, everyone.
Great, thanks, Laura. I saw a question come up in the chat. Shall we come back to those at the end or address them in the chat? That's great, thank you. So I'm going to be talking about how the NHS could provide greater support to those experiencing long COVID. And in this section, we're going to be discussing how the NHS is a trusted source of information for the public and should be taking a lead in the creation and dissemination of material regarding long COVID. A perceived lack of information from the NHS means many participants we spoke to were relying on a range of alternative sources, and many patients reported they were self-managing their symptoms outside of the scope of the NHS. So easily accessible specific guidance around long COVID, including how best to self-manage, would undoubtedly help people with long COVID. And the information that is produced should be developed for a broad audience base, including those who are unable to prioritize their health. So the next slide shows a chart with the data from our public survey. And as you can see on this slide, the public survey, people were asked in the public survey where they would look for information about long COVID. And the two most popular sources cited by respondents were the NHS website, with 66% of them, and GP practices, 59% of the public saying that. So at the next slide, we have got an illustration here. Sorry, just having a bit of a flash, waiting for the volume to be sorted out. Okay, so this slide demonstrates that almost 3 in 5 of the public said that they would trust the NHS most for information about long COVID, while half would trust their GP practice. So this really speaks to the trust that people have in the NHS for getting information that they need. and want. However, on the next slide, yeah, thank you very much. This data is also from a public survey, and it suggests that people aren't getting what they need in terms of information provision about long COVID. And this is really demonstrated by the public's divided confidence in their ability to identify if they have long COVID or get treatment if they have long COVID. So that's 41% of the public said that they would not be confident to identify if they had long COVID, or and 45% said they wouldn't be confident to get treatment if they had long COVID. Additionally, on the next slide, we talk about participants in strand 1 who were also typically not satisfied with the information they had received about long COVID from the NHS online, and also there was very low awareness of the NHS Your COVID recovery website, so the information that people were seeking was not readily available. Even when participants were aware of long COVID, they often struggled to access relevant information through NHS sources. And the things that were identified were sort of gaps in content. So online NHS and UK government sources were perceived to focus on the acute phase of COVID infection rather than the ongoing symptoms of long COVID. So that left a little bit of a gap. Also, a lack of awareness. This meant that participants did not always realize that help and support were available, which is something that Laura was speaking about earlier. We have a good quote here at the bottom of the slide that sort of demonstrate this. So there could have been some sort of supporting document in the event of you're suffering from long COVID. This is what you can do to help. This is what to look out for if you believe that you do have it. Sort of just a bit of guidance and support should be sort of more generally available and accessible. The other thing was information availability. So as a result of a perceived lack of information from the NHS, participants were relying on a range of alternative sources, which were not often regulated, and included sources such as online forums, Facebook groups, YouTube, and international. This is mostly US news media. So even participants from strand 4 who had been referred to a long COVID clinic and were receiving information from the long COVID clinics, they also reported seeking other forms of information, such as different self-management techniques. So on the next slide, we discussed that while the participants were aware that the information they found online may not be reliable, in the absence of what they felt was sufficient information and support from the NHS, many were still using these sources. And this we found could have serious implications, as we had participants reporting using a range of self-researched, self-management techniques. So at the most extreme end of the spectrum of people, experiences people were just talking about was one participant who was buying online injectable vitamin B12 supplements to sort of self-treat their long COVID symptoms. And we have a quote from that particular participant there on the right. So the next slide. This just really says that, clear guidance from the NHS would really help improve knowledge and reduce anxiety for people with long COVID. So because people's trust in the NHS and their GP practice for gaining information is so high, it means that really the NHS is in a prime position to capitalize on its position and as that sort of trusted source of information, and take a lead in creating and disseminating material about long COVID. And as I mentioned, this would help reduce anxiety as well as raise awareness that Laura was speaking about earlier, which is very important when sort of patients first develop symptoms or are first diagnosed, and it might also encourage more people to seek out healthcare providers. So participants did suggest sort of how the NHS could sort of produce specific guidance around long COVID. And so things to include would be prognosis, so whether they were likely to recover or not, and what partial recovery might look like, likely time frames, both for accessing any treatment they needed and for recovery, where to go for help, so particularly which organizations are responsible for services and pathways to accessing those organizations so that eligible patients can be referred more smoothly, what to expect, up-to-date information about treatment and support options available, and how to self-manage, so options for self-managing their symptoms. The NHS, on the next slide, it just highlights that the NHS should ensure that this information is easily accessible by using a range of formats, including audio and video, as well as written material, and disseminating information via multiple channels to help reach a broad audience base, including those who are unable to prioritize their health. Advocates from our Strand 2 interview suggested that the NHS could utilize voluntary and community sector organizations and their existing reach into marginalized communities would be really helpful. And this would sort of allow proactive outreach and information sharing. It is known that communications resonate most when they're from a person in a position of trust. So this would really help disseminate that information to wider audiences. Additionally, advocates also encouraged more hand-holding from voluntary and community sector organizations and peers to enable people with long COVID to access support. And I'm going to hand over to Kate now to finish.
Thanks, Michelle. Thanks, Laura. So another key part of the pathway where we found communication and information was really important for patients was when they had been referred to the long COVID clinic and they were waiting for that first appointment. So we found that sometimes people had had quite a winding pathway to reach that point. They perhaps had to have quite a few tests. They felt like they had to really drive that process forwards. So that could take some time to get to the point of referral. And then, of course, there can be some time while they're waiting for their first appointment, while they're on the waiting list. And in that time, they can feel quite desperate, really, and also quite isolated. So if we move on to the next slide, please. Thank you very much. It was a time when they weren't receiving very much support, and they really could be doing with more information, more support. And some of the particular types of support that came out from the interviews included the boxes here. So first of all, support from primary care. We wondered whether there were more things that could be done within primary care to start people with managing their own conditions and start them on that pathway while they're waiting to see the long COVID clinic. Secondly, we heard from people that had been referred into the long COVID clinics that the Living With app could be really helpful for them and was a really useful source of information. So might there be opportunities to give people access to that earlier in the process so that they can again start managing their conditions while they're waiting to see somebody? And then finally, this point is really about signposting to other support that might be available. So while they're waiting, particularly if they feel quite desperate, quite hopeless, perhaps they could also be referred to mental health services for support, like talking therapies. Also, things like peer support, which patients said was very, very helpful for them to be connected with other people who were experiencing similar things. And also, again, the self-management tools. So plenty of opportunities there to provide people for support while they wait. Moving on to the next slide, we're going to hear a few different clips from Vicky interspersed in here about what her experiences have been. So this is the first clip we're going to share.
I think, like, in terms of communicating and like that the long COVID clinic would really benefit from is talking to other parents and the children being able to talk to other children that are in a similar situation, because it's very, very isolating. And there's obviously the charity Long COVID Kids, which are amazing. They've been a lifeline for us. There's nothing there's nothing run by the hospital, and I'm not sure whether that's because of privacy, but I would have very happily, and I said this to them, I would very happily kind of write my name down and details if anybody else wanted to speak to another parent, but I don't know whether that's obviously not allowed, or there was nothing set up by them, which I think would be really good for I'm sure there's people with other illnesses that are in the same situation where there are support groups, but yeah, there's nothing like that, and you do feel very alone, like, in terms of like not being able to contact anybody at the hospital.
How helpful that peer support could be in people feel less isolated. In terms of information about the long COVID clinic and the pathway, that was also highlighted to us as really important to try and increase the amount of information that patients are giving. So while they were waiting, they described feeling as if they'd been forgotten. They perhaps hadn't heard anything for a few months. They were worried perhaps they'd fallen off the list. They were feeling very anxious about the process in this time when they're waiting. We also found that because they didn't know so much about what would happen at the long COVID clinic, and because knowledge of long COVID is patchy in areas, that actually when they went to the long COVID clinic, they were almost expecting a cure, that they would be able to walk in, have a consultation, be given something, and then emerge with a cure and everything's fine. Where clearly that's not the reality for people who are experiencing long COVID. So it's really important to manage patients' expectations in this time so that they can understand what help might be on offer and what they can expect to experience. Some of the specific things that we heard would be helpful were an explanation of what long COVID is and the wide range of symptoms that people may experience, because they may not understand all of their symptoms are related to long COVID. We heard that they would like to know more about what they can expect during their first appointment, and that really is partly about managing anxiety so that people can prepare themselves for it, but also so that they can manage their symptoms. So if they are feeling fatigued, if they are experiencing the brain fog, they can be aware of what's coming, try and manage their energy during that appointment. Linked to that, people wanted to know about the types of tests and investigations that they might be offered and the range of treatments that might be available for symptoms. They were very keen to have an estimate of when they could expect to have their first appointment. Again, even if it's sometime in the future, at least knowing that would give them something to aim for. And then also details of who to contact if needed. So if they did need to check in and if they did want to check on timings, or if they were having particular difficulties, they would have somebody that they were able to contact. Alongside that, they were very keen to have any signposting to support available to them while they wait. For example, the peer support that we've already talked about. So a very important point in the pathway to be managing people's expectations and help them manage their anxiety. I'm going to hear a little bit more from Vicky now on the next slide.
Hannah's not had, so other than the initial assessment report, we've not had a single set of notes, and I've constantly chased for notes for her medical records. She was discharged in January and I'm still chasing, I'm still waiting for the discharge report. So she was under the care for a year and there are no notes on her. So if somebody was to pick up her file, like her file with a GP, there's no note, like they wouldn't even know she was poorly, other than the fact that we've since taken her, since she's been discharged from private long COVID clinic because she wasn't better. So she was discharged because they couldn't do any more, but nobody's following her. Like nobody's actually that the follow-on care, having been discharged from a long COVID clinic, there's nothing. You're kind of on your own. So you have no option but to go private, which is whilst we've been really fortunate that we've been able to do that, obviously there's lots of parents that wouldn't be able to do that, and it's not really fair. All the children should have the same care and the same like treatment.
Okay, moving on now to the last part of the pathway where I think comms and information are particularly important. And this is when people are into the long COVID clinic, they have their first appointment. Moving on to the next slide. There's 4 particular areas where information and comms emerged from the research. I would say that this was a series of 42 interviews, so there's an awful lot of insight that came out of the interviews with people that had gone to long COVID clinics. We're just specifically focusing for this presentation on the information and comms part, but there's plenty more information available. So on the next slide, the particular areas where this emerged. So first of all, we found a lot of our participants described having an initial call with the long COVID clinic. This wasn't necessarily the assessment, it was more a call to find out a little bit more. And that initial call was really very well received. It was viewed as an opportunity to find out a bit more. It made people just feel like they hadn't been forgotten. They were in the system, they were going to be seen, they had the chance to ask questions. This didn't happen for all of the participants for patients using long COVID clinics. The second area people talked through was very much a, again, it was about helping them to manage their symptoms and manage their time. Sometimes they described us being asked to fill in paperwork or long questionnaires, and they said they were asked to do that with very little notice. So the example here in the quote, they called me the day before the clinic appointment and said, there's loads of questionnaires that we'd like you to fill in advance. Could you please do them? So they were looking for stronger communication from clinics to give them advance warning of these things so that they can manage their energy. They also talked about things like, is there a way of primary care and the long COVID clinic communicating better so that perhaps some of the information that's already been collected could be passed on rather than needing to ask the patient for that information again. It's also important to tell patients what they could expect at appointments and how long they would last. So there were examples given where people, they expect a normal appointment, so to speak, a half an hour appointment, and then when they attend, actually the appointment is much, much longer. And there are brilliant aspects to that. People described such good first initial consultations with their clinicians where they felt very listened to, they felt that their symptoms had been validated and their condition had been validated. We heard lots of really good aspects of best practice where things worked well. But these are on the communication side where things could have been done a little bit better, just in terms of managing people's expectations. And finally here, for some patients, they would have liked more guidance and more support with self-management. So as you would expect in a patient cohort, there were many different groups of patients, some of whom were very much looking at the latest research, had already done lots of research on the best ways of self-managing and were doing those things. Whereas there are other groups where perhaps that self-managing is more tricky, harder for them to fit it into their lives in terms of what their priorities are. And they just need a bit more guidance on how to follow those guidelines. So for them, perhaps a little bit more guidance, a bit more support along the way would be beneficial. We're going to pass over to another clip from Vicky here.
So we were told by the long COVID clinic recently, or when she was discharged, that they're actually an assessment service only. They're not there to treat or do any tests and things. They're there to assess only, whereas at the beginning it was very much, so it's almost like they changed what their format was from when they first started the clinic to when Hannah was discharged. So is this an assessment clinic only? They're referred back to a local paediatrician. So whilst they're supposed to be the hub for the long COVID kid expertise, when their children get referred back to the local paediatricians, like Hannah's the only child that the local paediatrician's got with long COVID. Like they've said that to us, because soon she said, the paediatrician said to us, well, I don't know what we're supposed to do because she's got no knowledge of long COVID. And that she thought that the long COVID clinic were there to treat and manage and like look after Hannah for her needs for long COVID, but that's not the case. It's just assessment. So the local paediatricians don't know what to do with the children because they've got no knowledge of long COVID.
Moving on to the next section then, we spoke to the advocates in particular to get their tips and ideas on how to communicate with different groups of people, and with a particular focus on people, the three groups that we selected for the Strand 1 research, with people experiencing barriers to accessing long COVID care. So we wanted to share with you some of their ideas and tips for communicating with groups. On the next slide, the advocates asserted for these particular groups, sometimes it was a struggle for them to know where to look for help. They didn't know where to go to find out more. They perhaps didn't have time in their lives to be able to do that. In particular, some of the advocacy organisations pointed out that the existing resources were not accessible to children and young people, to those who might have different access needs or who are digitally excluded. So a couple of the quotes here demonstrate that. And the first quote on the left-hand side is from a housing supplier. He points out that people experiencing homelessness have severe literacy barriers, and that in itself is a barrier. And they said, we've seen an awful lot of people come through where English isn't their first language. So accessing services for long COVID, as for any health service, this isn't particular to long COVID services. It can be a huge barrier, the literacy. And on the right-hand side, from Bernardo's, we hear a lot of families can't afford broadband and internet connectivity. So they work with Vodafone to try and support people to access information online. So opportunities for doing things to provide information to groups, it may be more difficult for us to reach. We did find that confidence and trust in information provided by the NHS is high. It is the first place people will look. What we heard in particular was the importance of developing communications and developing materials in partnership with people who have long COVID, so that the language that's used is correct, so that people are able to follow the guidance that they're given. And that includes involving a diverse audience, so reaching to a wider range of people, including children and young people, to make sure that the materials can be understood by them. Providing those materials in a real variety of formats so that they reach out to different groups of people, different formats will work for different people. And then also disseminating that information via multiple channels to enable access for vulnerable people and those from deprived backgrounds. So types of things we were hearing were reaching out via voluntary sector organisations who already have relationships of trust with groups who can then reach out and provide information. We also heard about community organisations like libraries, community centres and those types of places where it would be good to reach out to disseminate information to try and reach people who might be experiencing long COVID but don't know so much about it. So just in a summary, these are the 5 areas that we've highlighted as being particularly important from an information and comms perspective along the pathway. So we've talked about the importance of increasing awareness and knowledge of long COVID as a condition, because sometimes people aren't aware of it or they have specific bits of misinformation which provide a barrier to accessing services. We've also heard about providing better advice on the NHS website so that people know that there are services to access and how to access them, sorry. We have talked about providing more information at that crucial time when people are waiting for a first appointment. And we talked about ways in which best practice can be embedded further and information can be provided to people once they're into the long COVID clinics. And finally, we've talked about making information easily accessible via a range of formats and working with partners such as the voluntary sector to communicate that to a wider range of groups. We are now, I think, going to move into the breakout groups.
Kate, may I interrupt just for a moment?
Yes, I'd love you to, Ruth, thank you.
It's been brilliant and you are a very well-rehearsed group, so thank you for your brilliant handoffs. There was a question, I think, from Mo at one point. He put his hand up. So I just wanted to pause and see if anyone else has questions. I think you stimulated a lot of chat, i.e. a lot of comments in the chat, which I think the team have been responding to. But particularly Mo, but anyone else, if you have a question, could you please let me know? And Mo, I'm going to ask you to open your microphone up and ask your question. I'm not sure if you've...
Yeah.
Oh, perfect. Thank you.
I think I was trying to kind of follow on what Vicky was actually saying. We keep talking about long COVID clinics, assessment, and all that. The fact is, it's only the rehabilitation clinics that phone patients on their first contact as for assessing them pre-visit and so forth, not the so-called treatment something. As a matter of fact, I don't think I have actually seen any clinic designated as long COVID clinic. No, they are not. They are the usual clinic that has been operating where the patient with morbidity or long-term condition has been visiting, that they visit. They are not there specifically for long COVID. And in some cases, like Vic was rightly saying, I asked this question to a pediatrician in one of the meetings we had earlier this week. I don't think they are there to actually look at long COVID. They are there to primarily assess the child regarding psychology, psychoanalyzing the child. The behavior is likely to be mental rather than physical. That is one of the greatest mistakes. So the pediatrician should be actually trained or learn about the condition, long COVID. I remember that in one of the presentation, or is it the announcement by, or this press release by Downing Street during the COVID season, I remember one Professor Van Tam saying categorically that it is established that long COVID does not affect children. And as a result, that's actually killed the interest in people presenting reporting conditions. But he was wrong. And he hasn't come out to actually address that anomaly. So this is the reason why pediatricians don't look at long COVID in children as a condition. They see it as there is a mental illness, so therefore they can be dealt with by psychological psychoanalysis. No, it cannot. So I think, and we haven't tried, you see, of all this information dissemination, printing leaflets and distributing is good. But have we actually been trying the media, television, press, making it release to them so that because people will see what they believe what they read or watch from their news. But they haven't. BBC could present a program on it. They haven't. ITV tried something, but that was regional. So we are not actually presenting or educating the public as to what long COVID is. And like you rightly mentioned earlier in your research, that people are given false belief that when they go to these clinics, they will be cured. We are not being realistic. The advice should be realistic. It is not for cure, it's for how to manage the condition. That is what they should be putting forward, not giving them false hope that they are going to be cured.
I'm going to see if Kate, Michelle, or Laura have any thoughts or comments, because I think you're picking up on some themes that they've been exploring. Bring it to life. Any thoughts or comments?
I think some of what Mo points out, absolutely, we've seen in the research as well. And I just take this opportunity to thank Mo and also Vicky. They were our lived experience partners in the project, who made it immeasurably better by having their input. So thank you very much to both of you. But yeah, we've definitely seen some of what Mo's. Sorry, Mo.
Thank you. You guys did a good job. I know I've seen the report already, so that's why I've not been, following it because I've already seen it, and I see you guys did a good job. The trouble is not with the clinicians as such. Most clinicians still don't understand what long COVID is. GPs don't know where to refer to. And not only that, when you go to these clinics, they have information about the patient on the NHS record, which the GPs cannot access.
Yeah, I think we heard that very clearly, this continuity.
Exactly.
So I think that's a great segue to perhaps, I don't think there's any other questions come through at the moment, but Mo, that's a great segue to perhaps handing back to Kate to brief in the task, because I suspect it's picking up on some of those themes.
Thank you.
But Kate, may I hand back to you?
Thank you. So we have set up 3 tasks that we thought might be helpful. And so in each group, if you pick up the task that is for your group number, I'll read through them in a moment. While we are specifying this, if you go into your group and you think, actually, this isn't going to be very helpful for us to do this particular exercise, we'd really like to do a different one instead, please do that. Please do what is most helpful for you yourself. So in groups 1 and 2, we were going to ask you to plan a comms campaign to increase public awareness of the symptoms of long COVID and the variety of symptoms, what people can do to self-manage, and also how they can access help for their symptoms. In groups 3 and 4, we were really focusing in on the underserved groups. So have a discussion specific to raising awareness of long COVID, how to manage it, how to access health services, how that can be disseminated into underserved groups and which channels could be used to do that. And then in groups 5 and 6, focusing at the latter ends of the pathway. So discuss what support and information could look like once people have been referred to a long COVID clinic and they're waiting for that first contact. So in that time when they're waiting, what are the very practical things that could be done to give them more information? We're going to have 20 minutes, I think, to do that, Ruth. And then when we come back, I wonder if our Penn colleagues and NHS England colleagues, just one person from each room, can just highlight the one very practical thing that the group really felt was the key area that could be done, could be worked on.
Perfect. Okay, so I'm going to ask Helen to maybe put that into the chat, those tasks, and just going to pick up the baton from you, Kate. So at the moment, we've got 21 people online. It may be a little bit around that. So we're going to suggest that we don't break out into 6 groups. We break out into 3 or 4. So, so that we have a good mix in the room and you have a chance to chat. So for those of you who've already been on the session, ignore everything that you've heard to date about the breakout rooms, because we're going to mix it a tiny bit. I'm going to suggest that breakout 1 is anyone who has a surname that is, hang on, let me just think about this. So let me start off with the main room. Main room, if your surname is starting with A or B, stay in the main room. Okay, I'll pick up the task in a moment. If your surname starts with a C through to an L, please could you go into breakout room 1? And the recommendation there is you're thinking about the comms campaign. If your surname starts with an M through to R, please could you go out into breakout 2? And your challenge, if you like to accept it, is thinking about the undeserved groups. Underserved. That's me reading my writing terribly. Underserved groups. And then if your surname starts with an S through to the end of the alphabet, could you please go into breakout 3? And that is around what support and information would help people while they're waiting. People in the main room, it's basically which one of those do you fancy chatting about? Is everyone with me? Mo, if you have a problem leaving the room, just stay in the main room, and that's the same for everyone. If you are clicking on the link and it's not taking you anywhere, don't worry, stay in the main room and you can pick up the conversation with the people in the main room. So there should be about 6 people in each room, if my maths is right, something like that, 5 or 6. We'll run around the rooms and make sure that they are. That should mean that you have a good chance to have a conversation and meet some people. When we come back, we'll have a quick debrief, as Kate suggested. Kate, is that okay? Have I explained your task clearly enough?
Absolutely beautifully, Ruth.
Oh,
I think
perfect.
if we're Ipsos, we have one person in each of the breakout rooms.
Perfect.
Towards the end, we'll just summarise with the group what's the one thing that you would like to feed back. If somebody could do that for us in the main room, that would be amazing.
Okay, so Kate, I guess you might go in 1, Laura in 2, Michelle in 3, just to make that super easy, unless you've already corresponded with each other, and one of us will stay in the main room, which is normally Nina. We've got 20 minutes, so it's nearly past, so just at, my maths is so bad. Whatever 20 minutes is from here, oh, that would be 49.
10 to.
Thank you. Someone knows what they're doing. We'll remind you to come back into the main room. I hope you have really good conversations and let us know if you've got any problems. Please click on those links. I think they're in chat and I think the slide is there as well. Let me have a look and we'll see you on the other side. Enjoy your conversations.
Oh, Mo, I think you're on mute if you were saying something then.
Oh, sorry. How are you?
Okay.
Nice to see you.
Yes, you too. Thanks for joining. Let's see who we got left. We've got Mo, Natasha, Michelle, and I'm not sure if we might have other people whose cameras are not on, so just having a quick look. We've got Michael and Martin as well in the room. And Trisha, if I'm reading the list right. But I think we were the group that were not officially assigned a task. So we've got the choice of 3. We can either concentrate on, I think the first was the trickiest, to be honest, the kind of planning a comms campaign, but basically how can the NHS and the systems increase awareness of long COVID amongst the public? So that was task 1. The second one we could look at was raising awareness of long COVID and how to manage symptoms and access health services, and how to disseminate that information into the more underserved groups and through which channels. And then the last one was what support and information could look like once people have been referred to a long COVID clinic and are waiting for the first contact. So does anyone have a preference which one we could talk about?
There was nobody, there was only myself and Vicky in the group one, group 1, so we've come back to this instead. So, and that was the first one, campaign.
Well, we might as well
do that.
Get onto that one. Yes.
Okay.
Yeah. Well, why don't we really talk about the channel of communication? Because this is the problem we're having. In America, any little research that was done, the outcome is easily broadcast on CNN News, on Fox News, on all the popular news outlets. But here in the United Kingdom, we don't see anything like that. BBC spend their time talking about scandals, about unnecessary things, about Ukraine and all that. But no one is telling people how long COVID affect the population or the body. It's as if, you see, as far as I'm concerned, I've not had a single news outlet from BBC discussing long COVID, how it affects people, or what research is being done. This is the problem, because see, printing leaflets is fine, but how many people can actually what they call learned enough to read and understand what's in the leaflet? You see, it might surprise you to know that 80% of the population are illiterate, and most of them live in rural areas. So they don't actually, they get this leaflet, just look at it. Oh, if they see a fine picture with someone, they look at the picture, and that's it, and then they chuck it. See, but the press should do more. Actually, no, I think I blame the NHS. Should do more by, see, BBC is what they call a government channel. ITV4 is a government channel. They can use these channels to disseminate information, because it's health, it's public health. So I don't see why we can't use it.
Yeah, and I think that's a good point. So I was going to ask, what does everyone else think about that in terms of kind of the channels that things should be communicated through? I know we've got a comment from Trisha in the chat as well, that communication is key, and making sure that the factual information that's been gathered is known to the public through things like public speaking.
I think from a parent's point of view, I mean, my child got ill December 2020, and since then it's been such a long journey, and it's been an awful journey. It hasn't been good at all. It's been dreadful. And I see the children now who are, you know, I mean, I just think it's ridiculous. I was talking to a mum who's got a 9-year-old who suddenly can't read and write. Exactly. And yet they go to the hospital and they're told that it's a psychological reason. Oh, they're not told. The neurologists are not saying, actually, there's a chance this child has got long COVID, you know, and that's the reason why. They're getting told it must be trauma. They must have been bullied at school. And it's so appalling how you can go to a long COVID clinic in one part of the hospital and be believed and validated, and you go to the other part of the hospital and be treated like that. It's just wrong. So I do think that posters on the walls of, you know, when you go into a GP, when you go into the hospital, you know, it should be there, posters on the wall about it, about all the symptoms a child can have, including physical symptoms, you know, including the loss of ability to walk and things. And they should be in all the local children's wards. They should be on the walls. They should be on the in the main hospitals of children. And so if the parents are going in and seeing these neurologists who are saying, oh, it's all in head, it's psychological, they then can look at a poster and say, hold on a minute, children can get all these symptoms and it can be long COVID. And actually they need to understand that they might not have been tested for COVID and they might not know they've had COVID, but actually this might be the reason why, because they need to be given that information, that empowerment to say, because otherwise they're just left, aren't they? And they're just like, we're never going to get any chance of help. It's just wrong. So I really think those posters absolutely have to be everywhere, absolutely everywhere. And really not just our anxiety and fatigue and things. They need to list detailed, and the fact that it could be movement problems, it can be all sorts of things, and that this can be long COVID. It's so important. And it would have been fantastic at the time, when my child was ill, to know that. And it's not, you're not just dependent on a doctor saying whatever their opinion is, or a neurologist, whatever stance they come from, that you're actually got, you've got that there, haven't you? So I think that would be really, really helpful.
Natasha, do you want to come in as well? You've got your hand up.
You're not speaking, Natasha.
Sorry, was that me? I didn't hear my name.
Oh, don't worry.
Sorry. Yeah, I completely agree with you. I think there is an absolute need to have a national campaign and to have a top-led campaign. So something that communities can access and utilise. But also, one of the things that we're doing in Sheffield is we've been funded in the voluntary sector to actually get some of those resources developed by the communities themselves. So we've been looking and sort of holding sort of citywide workshops on how communities are communicating around long COVID, and particularly learning from the pandemic, from the experience of how people worked during lockdown, what resources were being used, those, and utilising those connections and those pathways. So just give you some examples, we found that there are absolutely huge community groups that are, as Mo indicated, high levels of illiteracy that only communicate through WhatsApp messages. So we're producing a series of like TikTok videos for them to pass around the WhatsApp community groups, produced by young people and produced by people in different languages and with different formats. I think it's really good that we can do that, but I would have really benefited during this process from having some really clear information that I can just roll out to get that conversation going. Exactly. As it is, I have had to start from scratch really with it all, and it's just been it's not just hugely time consuming, it's actually really expensive. So one of my other questions is, how is all of this going to get funded? Because it's all very well asking the community groups to work on resources and do all that sort of joint working and communicating, but this all costs money, and where's that going to be coming from?
Of course,
that's my 2 pence.
Not sorry. Just ask quickly. Imagine if what is happening now happened during the original pandemic, and that the government did not go out of their way to propagate this through the media. What would have happened? A lot of much more people would have died because of ignorance. You cannot take relating the symptoms to neurology or something is quite wrong in my opinion, because I believe that it is the condition that leads the children to developing that neurological issues. It is not neurology that brings the condition. It is a condition because when you are frustrated about something and you have nowhere else to go, you hit a dead end. What do? So I think the government has to. The government will act, but if the NHS so-called managers actually get out of their backside, and I'm sorry my language, and go out and tell the government, look, this is what is happening. This is what we think we should do that will improve the condition or the awareness. But they haven't done that. I don't think they've done that. They could provide funds for it. If they ask the government for funds, they will provide them with funds. But they are not doing it. They provide funds for idiotic ideas that they develop to increase their take-home pay. They are not actually focusing on what is happening. So I think I'm not blaming the government for not providing the funding. I'm blaming the NHS fund managers for mismanaging the funds. And I've actually told them this in meetings, because there's much more they can do. For instance, okay, every month or so, Amanda Pritchard, the chief executive of the NHS, have what they call all staff meeting, where she comes out and discuss what is happening, praise staff for their work, tell them what's on the pipeline, and ask them to come out if they have any issues. And that helps the NHS to the staff to come out and then do what they call whistleblowing or something. And that has improved a few things. But I don't see anything about the condition. In America, you go to any channel, they will tell you this is what is happening to long COVID, this is what the symptoms that they are suffering and so forth. We don't have a clear symptom here, do we? No. We only list fatigue, tiredness, breathlessness, even brain fog is kind of a silent something. But brain fog is real. I have experienced it, and I know it's real. It happens momentarily. But for that moment, you forget everything. You actually disorientated completely. And then if you are getting a bit on the older side, they begin to think of dementia instead of finding out why. So we are very easy to associate a condition or something with something, rather than find out the root cause.
Thank you, Mo. Sorry, I don't know if my Wi-Fi is slightly paused, but yeah, thank you, Mo. I think it sounds like we definitely need a more detailed list of symptoms circulated, so it isn't just those top ones that people associate. I just wanted to invite Catherine or Pamela as well, and Vicky. I see you here as well. Yeah, if any of you want to contribute before we sort of end our session.
Actually, I have a list here from an American research, which let me see if I can share it.
Oh, Mo, thank you very much. I'd like to hear from a few of the others as well, just on this sort of topic about communications, and it'd be great if you share that in the chat maybe, or the end. All right, thanks, Mo.
I would like communication between doctors too. I want the doctors that gaslight, and they do gaslight. They're dreadful. I had one doctor pass a funny comment about, it's just like a scene out of Little Britain.
Exactly.
My child's in a wheelchair, and then it's just, I could tell you some heart rendering. It's awful. I think doctors need to know this is not acceptable. You can't do this to anybody, let alone children. You can't treat them like that. And the communication needs to go out as a firm, almost like a warning to them, that they need to, all these doctors who deal with these patients, they need to, whether it's in their own time or not, to learn about it, and they need to stop behaving like it. Communication should be like that as well, because otherwise I'm just talking to loads of families who are treated like it still, and it's just, it breaks my heart that the children are being treated like it, and the parents too. And it's just so wrong. And it hasn't just got to be within the long COVID. It's got to be any of these children with any of these symptoms do not get treated like, they get believed completely and utterly when they don't get dumped in a psychological box. It's not right. It's just horrendous that it's been happening for so many years. It's so awful. But yeah, our communication to all the doctors that this has to stop. Just has to stop. It's just, there should be a public inquiry into it, and there should be, and you should be able to go there, and you should be able to say, certainly for my son, you know, the times he's been treated really badly, and it's just awful. He wouldn't want to go to near a doctor. I mean, private ones now, but you know, an NHS doctor, he wouldn't want to go near them. And it's so sad to see, you know, to see children that'll be with them forever, won't it? All through their lives, they'll feel they've been so disbelieved and let down and pushed into the fact that you must be making up this brain fog. I mean, you can't read and write, but hold on a minute, this must be, you know, how it's just ridiculous, isn't it? I remember one neurologist saying that 90% of people who have brain fog have it, and they just let it go, and 10% hold on to it, and they're the ones, just like my son, that hold on to it, like he has some control over it, like his ability. It was like vascular dementia, you know. It's so wrong that they get treated like it. It's so wrong. And just get up and walk. You know, you can just make yourself get up and walk, and they're still getting treated like it now. When do those people in power that treat these children like it, when do they get stopped? When? Why is it always accepted? Just, I can't believe it's still going on. It's just so awful. So communication to them as well. They have to know that they have to know that, or get a public inquiry into the whole business of how neurologists have had this power all these years, and because they don't know and they don't understand what's going on in the body, so, or in the brain and whatever, so they'll just dump it in psychology, and then they can just gaslight and say, well, you've got a mental illness, you know, your symptoms, you do have them, but they're because you've been bullied at school or some other thing. You know, you're coerced into having to believe that that's the reason you've got a psychological illness. You haven't got a psychological illness, it's a physical illness. But you're coerced and bullied and cajoled into it. And as parents, you're frightened into it too. You're like told that if you don't make your child get up and walk, then they might, you know, it's use it or lose it. They might lose their ability to walk. So you have to make them get up and walk. And like I've got parents saying now that they're not given wheelchairs and things like that. It's just, and the children can't walk, and it's still happening. It frustrates me that they're still getting, children and families are still getting treated like it now. You need to do something about it, and you need to do something about it now, and it needs to be strong. Sorry.
Right, thank you. No, that's really clear, and I think, you know, we did sort of address that, didn't we, a little bit with the raising of awareness and knowledge in healthcare professionals, but I think you've added something extra of just the behaviour and the respect, so that's really important. Thank you. Did you want to add anything, Pamela or Vicky, before we end?
I just wonder if I know that we are talking a lot about DL care, but for the children that are, let's say, lucky enough to be in educational settings, personally, I think that probably we need also a little bit of a campaign with a teacher or the support group in nursery, or just go into the direction of camps and everything that might be directed into that sort of action, and be a little bit sort of wider, because why in some settings, of course, probably the parents are the first one that realize something. In some situation, it might be the educational settings, or and so I think that it's also a route that it's worth to explore with the healthcare route, and of course the GP and
Thank you, Pamela. I think everyone else has rejoined us, so
they have virtually rejoined you. I can see that room 2 are still probably in the technosphere somewhere. Oh no, I think they're virtually back now. Yes, they are back now.
We're definitely back now, room 2. We were the errant group.
Not at all. So I'm going to hand back to Kate, Michelle, and Laura, and see how you'd like to progress now.
Thank you, Ruth. So I think if we run past our 3 groups and give the main 1 or 2 things that came out, and then perhaps someone can pick up for the main room. Since I have the mic, I will start. So I was in room 2, and we were talking about how we could disseminate information about long COVID and the support that is available to underserved communities. And the 2 key things that we came up with, first of all, was about using existing networks, and that's from 2 perspectives. One is just about not reinventing the wheel, like use what's already there. The second part of that, though, was to be able to reach out to people who wouldn't attend like a talk that's put on, because you'll have people coming that, you know, already have some knowledge and experience of long COVID, and to use groups that aren't just healthcare related, So be working with groups where communities get together and use that as an opportunity to reach out to people. And then the second part of it was just to be bold, just try stuff, give it a go. It's a learning process. Try things, get feedback on it, try it again, be innovative, think about different ways of trying to communicate with people beyond talking to them. So different ideas for how to engage people. Those were our key practical tips that came out. Michelle, so we come to you next.
Yeah, sure. So I was in room 1, and we actually set off on the path of looking at communication channels as well and dissemination, but we sort of evolved into designing a comms campaign, but nearly. So I think what we really decided was that a national campaign is needed, and things like just posters up on walls, but really detailed symptoms of what long COVID is, what that really looks like, and particularly with children. We had a number of people in our group who were speaking from perspective of children, young people. And just to really say it's not just only anxiety and fatigue, but it can be loss of mobility, loss of ability to walk. So it's really important that people have that knowledge at their fingertips, and then it also empowers them when they go into appointments where they can, if they feel like they're being sort of gaslighted by a doctor, they can sort of point to these posters and use them as a way to kind of empower them to have those conversations with the doctor. And I think, as well as we did really touch upon as well that sort of doctors may be attributing symptoms to non long COVID conditions, and that it would be good, and as well as educating healthcare professionals around awareness and knowledge in long COVID, but also changing maybe their behaviour and in terms towards patients, in particular parents and young people. So yeah, that was our campaign, the start of our campaign we designed. Over to you, Laura.
Thanks, Michelle. I was in room 3, I think. I've lost track now. And we were talking about the support and information that could be provided to people between their referral to a long COVID clinic while they're waiting for that first contact. And so essentially the message was that it's better to provide a holding message and some tools to get people on the road to recovery, rather than just letting people wait and not have any information. There was some conversation about how wording is really important. So rather than giving people information about self-management, which can be quite intimidating and scary, it's better to describe it as things like symptom management and thinking about tools on the road to recovery, rather than allowing people to think that they're going to come along to this appointment and be cured. So providing clarity and options is really important. And another point that came out was just about different parts of the country approaching long COVID referrals in different ways, which makes things really complicated and confusing for healthcare professionals and for patients. So having a more standardized approach would be really helpful.
Thanks, Laura.
Wow. And I think there were only 3 rooms. There were 3 rooms in the end, because we merged the poor lonely person with another room.
Perfect. Well, I think that's us concluded, Ruth. If I could just finish very quickly to say thank you to Vicky for recording the clips for us. It was very kind of you to do, Vicky. Thank you.
Yes, Vicky, really helpful to hear your thoughts. Thank you. Where were you?
I was on holiday.
The sun was shining.
It was very nice. Got back this morning, but there was lots and lots I could say around, like, so much about long COVID and specifically children, and our experience, which I'm sad to say hasn't been particularly good. But yeah, so if anybody's got any questions for me, if they want me to elaborate on anything, then I'm very, very happy to do so, because probably, well, I know my experience isn't like unique. There's so many parents that have had the same experience, and I'm sad to say the long COVID clinic didn't help at all. They were very, very kind, very compassionate when we spoke there, when we went there,
but they were able to offer, well, other than trying to kind of force it down, which is a lot of other people have said, down the psychological route, which absolutely was not the case with our daughter, and a very kind occupational therapist and physio. There's no research going on, there's no treatments being offered, and yet we've had no other option but to seek private help, and they have been able to help, and they have been able to offer treatment, and it has helped. And my daughter's learned to walk again. She's getting some of her life back, which I'm sad to say that lots of children aren't, and you're stuck in this cycle of not knowing where to get help, because once you've been to a long COVID clinic, there is nothing else that you know. And I think the main thing again is, and I know it's about communication between the GPs, between the paediatricians, and between the long COVID clinic. I think unfortunately paediatrician believe that long COVID clinics are going to take over care of children and are there to help and manage, but they're not. They're there to literally say whether your child has got long COVID or not. Basically, that's what it comes down to. And if they need psychological intervention, then they're to chat to them. So whilst it's very, it can be helpful in terms of holistic therapies, other than that, you kind of hit a dead end, and you've got seriously ill children that are getting no help at all and no treatment. And parents that feel, as Catherine mentioned when we went in the breakout room, you're gaslit a lot by doctors. Some doctors can make you feel like you're not necessarily making an illness up, but kind of exaggerate, feel like you're making a fuss about nothing almost. I mean, and it was clear that our daughter was really, really poorly and she couldn't move her legs. And yet the first thing that was said to us was, is she being bullied at school? It may be psychosomatic. And it was just like, you wouldn't say that to an adult. So
no, and I think you've just really pulled out the red thread that's gone through the day, which, well, there's a couple of red threads. One is our children, young people are, I think it was captured by the quote that Kate and the team shared but didn't pull out. He knows his childhood is going. That's not okay for our young people, is it? And we heard that echoed across the day with, at risk of not coming out with qualifications. But we also heard that, and you've picked up real issues around stigma, gaslighting, health inequalities, that you need to have a spotlight on them, and linked with that, the lack of information. So you've got this kind of real challenge where you've got people finding it hard to get information, finding it hard to be taken seriously, and being discriminated against in some form. And therefore, the really shocking truism that their safe haven isn't their family sometimes, it's peers, patients, patient advocacy groups, charities where they're going to for their help. And how do we make sure they go to the right place is one of the things I heard. If they're lucky, they may get a long COVID clinic place, but then there's this massive wait. And how do we self-management? I actually really like that symptom management, because I think self-management sets us up to fail in many ways, with some really interesting pointers around the Living Well app, peer support, a call from the clinic, so people aren't lost, forgotten, anxious. And we heard some really strong and powerful messages there. And then the real thought that needs to go in once you're in front of a clinician, a healthcare professional, that they've really understood the impact, the cost that it has been personally to be there, and that they are listening appropriately. And we heard a lot of clear messages where that's not happening well enough. So making sure that the impact of the clinic visit is worth the cost to the healthcare. And then some real issues around discharge, making sure it's joined up, and people being discharged because there's nothing else that can be done doesn't mean they're better. And this very, very real issue. And what Neil said, coming back to the beginning, being able to learn from each other and develop solutions and approaches with our diverse audience is critical. And on that note, I wanted to thank all of our speakers today, all of the contributors. I wanted to thank the NHS England team particularly Joe and Nina, for making this a possibility. But for all of the speakers, it is as expansive as I can make that. So all of the videos that we've had today as well. And thank you, the audience, for joining us, because this has felt like a real blend of research, academic insight, patient perspectives, and clinician commitment. We're not going to get the answer on one webinar, but I think there's definitely some steps forward. We will post everything on our website, so when we share the link with you, that means it's there. But as you were talking, I think one of the suggestions was reaching out to groups and audiences. We have a lot of best practice on our website where organisations have done that effectively, not for long COVID, but for other things. So if you're looking for inspiration, I think it may be useful to sit on our website and have a mooch. So thank you, everyone. Thank you to the Penn team as well, Louise and Helen, you're brilliant as ever. Thank you, Nina. Thank you, Neil. Thank you, all of our speakers, and thank you for staying with us today. On that note, bye-bye.
Thank you.
It's been a real pleasure.
Thank you.
Vicky, thank you. Mo, thank you very much.
Thanks. Bye.
Bye-bye.